And it's a pleasure to be here. Talk about a program near and dear to my heart. We're in about our 15th year of running CYACC as funded through our state Title V agency. I don't have any disclosures. I'd love to, but I don't. I'd like to thank Title V in Indiana for their sustained funding for our project. The School of Medicine's Department of Peds and our county health system, Eskenazi Health, all help contribute to our ability to stay afloat. CYACC is not spelt like the boat, but it is said that way just to make it easier for folks. I'm going to talk a little bit about how we came to be and what we do. I'm going to talk a little bit about the tools we use, trying to expand more and more into using smartphones as the ubiquitous tool that all teens and young adults seem to have appended to them, and talk about how we also collaborate with primary care docs around our state. Our motto for CYACC is to steer youth with special healthcare needs to successful adult life. We try to use a transdisciplinary approach with nursing, social work, and medical professionals. We try to use a family-centered and a whole person approach. We invite referrals from anyone who has a transition need that exceeds the capacity of their current team. So we are not exclusively serving people with IDD. I'll talk a little bit about that distribution, but in fact, our largest population is the population of folks with IDD. This is our graphic of how we describe transition to families, to youth, to other health professionals. There's an on-ramp, there's actually a transfer bridge, and then there's an off-ramp. And it starts somewhere early in pre-adolescence or early adolescence to start working on climbing the on-ramp while you're still a dependent child within your family. As you start to become a budding yeast from that family, a developing youth, you should be doing a little more on your own. The walk across the bridge needs some railings. In other words, we as health professionals have to help provide those railings to get people from one side to the other. Developing adults are still often not fully independent from their family and therefore need ongoing scaffolding on that off-ramp. And there's some time, whatever T4 is, I don't think there's an exact number, and that's why we don't put numbers on our bridge. Somewhere around 24, 25, 26, most young adults have come around to recognizing what their needs are and engaging in being interested in caring for that themselves. We are charged with two tasks in our funding through Title V, both providing medical education to rising health professionals. We have a lot of medical students, residents, social workers, genetic counselors, nurses who come through our clinic for educational reasons. And then we provide clinical service delivery in consultation to individuals who are referred to us. We are not a long-term service. We are a consultation with brief care coordination and concentration on handing off to who's going to do the rest of the work. We are funded to care for folks ages 11 to 22, since that falls within the MCH catchment, but in truth, our oldest patient is 68, because sometimes people arrive with needs that are otherwise difficult to meet in the rest of the healthcare system. What our clinical service delivery looks like is something we hope to be a comprehensive assessment. We review medical records, school records, current service delivery, do a psychosocial health and functional assessment. We use a model of healthcare evaluation that is commonly used in countries that do a better approach to population health for people with disabilities, which is called the comprehensive health check, which attempts to find potential comorbidities before they cause significant problems. After about a 2-hour visit at our clinic, we conduct then a case conference for families, usually a week or two later, in which we list a whole scope of possible next steps for actionable goals. Then a conference call happens between a care coordinator and the family to kind of work on prioritizing those goals and figure out, in fact, how much help the family wants based on a combination of our medical and social complexity scoring that we use. I saw some people from Ocean on the call. We're currently using that tier assessment tool. We provide follow-up based on severity of need and family's desire. So this is a flow chart that kind of walks through. I should come to this slide right now before I talked about it, but this is kind of just the flow of how things work. After our team meeting, the portable medical summary and consultation note and transition plan here in the middle gets communicated to the existing or future primary care doctor or both. We engage in some interactive conversations there to say, we've started this therapy, but will you continue it? Or do we need to help you find a different specialist to help with that? So we really do try to emphasize the concept of warm handshakes so that we know if the receiver is going to do what we're asking for, or if we have to create an alternative plan. We use the philosophy that it is the sender's job to make sure that the receiver got it and is going to carry through. If the referring clinician was other than the primary care doc, we communicate back with them, and then we ask the family who else they want to receive this information. Sometimes they're working with a new adult clinician who doesn't have the whole picture yet, and we send information there. I think the chief things that our team would say they do as care coordinators is to help with health system navigation, giving advice about school and employment services and particularly accommodations. We do a lot of work engaging people in mental health. We do a lot of work encouraging community participation and growing independence in daily living activities. When people come back for a return visit, they might come at periods of key critical needs. So if we meet somebody when they're entering high school and they don't really have a lot of acute needs, and we've laid out a plan that they agreed upon as a next steps of what they're working on, we might say, well, at least come back before you exit high school, or at least come back before you decide what kind of decision-making support you're going to create for age 18. When people are in special education through age 22, we really strongly advocate they come back for a visit during their 21st year. So we're making a plan for what life looks like after completion of special education. And certainly there are other reasons people come. A patient I just saw that I just left the room of is planning a move, and she has significant physical disabilities. And so that's a big life transition of how to engage services in a new part of the state. So any kind of key transitions are good periods to come back for what we call a tune-up. And to think about the different areas that you might need to think about with an impending transition. We try to use kind of the philosophies of AHRQ in terms of thinking about what is efficient and effective care coordination, making targeted referrals rather than shotgun referrals, because we take the time to understand what's the family's income and what's the family's access in terms of transportation, so that we're making recommendations for maybe physical activity that fit in that family's life, rather than just is everybody should just go to Special Olympics. I'd love everybody to go to Special Olympics, quite honestly, but that's not really within the means of every family. Not economically, but I mean for many other reasons. So this is the inside of the CYACC brochure, and it kind of shows you our view of comprehensive. So this gets sent to everybody when we're scheduling their first visit. And it tells them these are the kinds of things we're going to talk about. We're kind of different than a usual doctor's visit, right? So we want to get people in that mindset before they arrive at us. And so are they already thinking about what their insurance options are? Do they know what a waiver is and whether that will meet their needs? What's happening at school now and what's going to be next? How are you thinking about learning to make decisions and deal with their consequences? And therefore, how do we get you to the highest level of self-advocacy? So I'm not going to read all of the questions. That's just a sampling. We call this list of 12 items our bucket list, because I think we might have labeled it when that movie first came out. I don't actually remember. But the bucket list reflects an attempt to make goals in every area. And in some areas, we don't have to make prioritized actions, but they're just still our goals. Who's going to be the person who supports you as a natural support in your adult life still fits in that box, even if we don't have to do an action to take care of that. I'm going to show you a de-identified transition report to help with that. When we first started CYACC, again through funding through Title V, we with the help of a bunch of youth advocates, we wrote a transition book. This is the index to that book. You can find that book on the Riley Children's Hospital website under Child to Adult Transition. We don't tend to give out the whole book to people because paper books are almost obsolete in the hands of young adults, I have to fear. And therefore, we tend to use targeted sheets when we want a specific action to happen. So if we're working on stress management, we give out the stress handout. A patient last week, I gave out the budgeting sheet because they were trying to think about how do I figure out if I'm ready to move out on my own, and budgeting is one of the first things to work on in terms of that. So welcome people to use this, any of the tools in that workbook. We learned early in our experiences that to be good at transition, you didn't need to have a plan for every diagnosis that a child might have or a young adult might have. Because many people get tied up in, well, what do we do exactly for sickle cell? Or what do we do exactly for cystic fibrosis? And what we learned is that if you categorize people into these 4 major categories, it helps predict their transition needs. So all youth have a set of needs. I'm going to talk about those in a second. And then there are youth who have a chronic disease that doesn't cause any disability, or a youth who has a physical disability, motor or sensory, or a youth who has intellectual disability or a serious mental illness, or some combination of those 4. And then we also have youth who have accelerated or high social complexity. Let's pick a child exiting foster care as a key example. And they have specific needs because of their lack of social supports. And so we tend to think about these prototypes and what kind of needs they have to help us systematize our approach to making suggestions for families. We see about high 200s to 350 families a year. Our average age, even though we invite people as early as 11, stays in the 16 to 17 age range. Of our 4 care coordinators, they all have about 80 what we call hot cases at a time. So they're people we've seen in the last 6 months or so that are still working actively with our care coordinators on transition suggestions we made from them. And then we welcome anyone who we've seen prior to call back in kind of with a question. And every question doesn't yield a return to visit session. It might be many times they're answerable by phone, but we monitor that just to have a sense of what our workload is. And every month, everybody gets at least 1 call per month of somebody they do something with who's not currently a hot case. Sometimes those calls generate the need for a visit because there's a whole lot of things going on. And so it's better for us to give them the full tune-up. So this is the way we break down like the kind of needs you're likely to have based on those 4 categories I mentioned for you. The first being that I'll step back because I should have done this slide first. Everybody needs sustainable healthcare financing. Everybody needs a primary care doc as a point of contact rather than using the emergency room, because young adults in America love to use the emergency room more than any other age of person. And they need to know enough about their own health history to be able to carry forward their care needs. Were they immunized? What's their family history? What kind of procedures have they had previously in their lives? So everybody needs that. Then if you have a chronic disease, what else do you need? Well, you need to know who are going to be the constituents of your adult healthcare team. Your adult healthcare team might not look like your pediatric healthcare team because the scope of practice of people in pediatrics and people in adult care are different. And so general pediatricians are experts at ADHD care. General internists or family medicine docs are experts at hypertension. You won't need a specialist to help you with your hypertension in the adult world, but you might need a specialist to help you with your ADHD management. And so those are changes that happen just because you're moving from pediatric to adult care. Young adults need to know what their treatment plan is. I hope that we stop and think about, have they learned everything they need to learn about their chronic disease from their healthcare team or from their family only? If it's been from their family only, then they've learned that filtered through the family's health literacy, and sometimes that's variable, right? And so how have we thought about preparing that person to understand their own disease? The classic issue is youth with cystic fibrosis. Who's counseled them about their procreation and sexual health needs. Who's done that for people who have spina bifida? Any group of people who might have altered sexual and procreational health needs. How's that gone in the pediatric world? Often we find it's new to discussion in the adult world. The whole concept of having an advanced care plan if you are a person who's critically ill, how's that gone in childhood? And how do we move into a new conversation about that in the adult world? The next group I'm going to talk about are those with physical disabilities. So we need to think about all the things we just talked about, plus what are all the things that the parent is doing or the caregivers are doing to support the person for accommodations, and how are we going to replace them for the person to have more independence? What environment, equipment, transportation, personal care do they need other than the parent to achieve a higher level of independence? And then what are the governmental and community supports for people with physical disabilities, and how do we engage them? For folks who have intellectual disabilities, there's a whole concept of how do we help the person rise to their highest level of self-advocacy. And this is a very complex concept, and I'm going to talk about that more later in the talk as well, because some parents are very good at promoting the inclusion of their youth and the stretching of their youth to do more, and some parents are very good at bubble wrapping for safety. And the right balance is somewhere between those two, isn't it? And so helping families find the right balance of enough support with enough freedom is really hard entering young adulthood. I've already mentioned puberty and sexuality as specific areas for really all of these patients. What kind of legal decision-making supports have you prepared for? I need everybody to make a spit pack with me right now that you will not automatically recommend guardianship just because a person has some limits in their cognitive ability. And that is a knee-jerk response that some families hear, and we commonly have to unlearn that learned skill of families when they arrive to us to help a youth with supported decision-making or power of attorney or some much less legally restrictive choice. Again, we want to engage the community and governmental services that are appropriate for people with intellectual disabilities when we meet them. People with serious mental illness are really the hardest group to help through transition for me still, because there are so many barriers to care. One of them is that the diagnoses we use in childhood aren't diagnoses that qualify you for services in adulthood. Another is that as a society, we struggle with addressing serious mental illness as a chronic disease rather than a personal fault. And then there's a lot of disease non-acceptance because of all of that stigmatization. And so all of that gets in the way of us treating serious mental illness like a chronic disease. And if we could just treat it like a chronic disease, then the things you need to do for transition care would be the same. But instead, we have to do this other work of breaking down barriers that prohibit that. Here's just a quick snap at what a year's worth of patients look for us. It looks pretty much the same year by year. And of course, COVID affected us like everybody else. So I'm using a year earlier than that. And you'll notice that 64% of our patients have intellectual disability plus chronic illness plus physical disability plus serious mental illness. And so that's what makes them super complicated, because everything I just went through are the things we have to talk about with families. And sometimes you have to make a choice between what services can you get if you have both physical and intellectual disabilities, because you can't have everything the way our waiver programs work in Indiana. You have to choose between A or B. And so understanding that can be a complicated phenomenon. We see a good mix of our state demographically in terms of the counties people come from. We see a good mix in terms of a racial distribution. In fact, we see a little oversampling of our minority patient groups. So we feel pretty good about meeting those needs from that perspective, perhaps. And then we see a heavily skewed population who have mostly public insurance, but you see the patients on waivers will have both private and public. So we deal with those combinations as well. Here's just an example of a transition plan. I'm not going to walk you through this at all, but it just shows how we write goals or status quo in each area to help families think and youth think holistically about their future lives. Do you have a trust? How are you going to learn to drive? How are you doing chores so you're learning to do household tasks? How do you get out in community, and what opportunities have we uncovered for you? Is school going well, or do we have suggestions for what to do in school? All of these are pieces of the, bucket list suggestions. I don't show this care map to make everybody feel like we're really smart at CYACC. I show this to remind you how complicated it is for families to navigate. And so prioritization and helping them with organizing their care needs is really important, because here we sit in healthcare in this little nice cozy blue area, but really the family's dealing with everything on the page, aren't they? When we first started doing social and medical complexity scoring, we used an instrument originally created by Robert Nichols at Oregon State. And we used this for a number of years. And I'm going to just show you a published study we have related to this, in which we correlated that for 100 patients who had pretty much the same distribution of diagnosis that I showed you on the prior slide, we found that patients were mostly in medium complexity from both a social and medical. Well, to come see us, you have to have medical complexity. So that's a pre-forma, but they were heavily concentrated in this group of patients that we define as family has lots of strengths, but they trip and fall because they have so much to do on the care map. And, but then we have a fifth of our patients are highly complex socially and really need hand over hand supports. And a smaller percent are capable of navigating everything they need and calling us when they need us. And so that's how we write that out on our transition plans. In fact, we group people as families doing a great job of navigating their needs, and they'll call us when they need us. Families doing a great job, but we're going to check in with them and see how they're doing after a little bit. Or family right now has lots of needs that we're supporting. And that's how we describe that kind of stratification based on medical and social complexity together. When we looked at that, we looked to see, well, are we doing different things to those different groups of people in the low, medium, or high ranges? And it won't surprise you that when people are in more complexity, we are less likely to do the things of like, let's find you a job right now, because we're really just trying to get the seizures under control, right? And if you have, and you're more likely to have equipment needs if you're in the higher end versus the lower end for a combination of complexity. But in fact, we do try to touch upon each of the bucket list items for everybody, just even if it is to make sure they know what their options are for the future. From a time perspective, do I want to spend time on this slide? This is just, it just shows what I basically said. I think that we do a lot of work in each of the categories of the bucket list. Of course, we don't recommend you for a waiver if you're not eligible for it. So, and about half of the patients who come to us already have the waiver and who are eligible, and about half don't. And so we do spend a lot of time teaching about home and community-based waiver services in our groups. Our average number of priorities we create for a family is somewhere around 8. And the needs have some changes by the different subgroups. You'll see here that people with chronic disease are more likely to need help, are not more likely to need help with planning around school. It's the people who have the other disabilities that need more help, physical and intellectual, about planning about school. People with physical disabilities need more help with home modifications. None of this is going to surprise anybody on the call. People with intellectual disabilities are the most likely to need help with decision-making supports. I think the last one might be the one that's interesting to people. Our patients with serious mental illness are the least likely to have a PCP. So they need the most help with hooking up and encouraging to use primary care. So let's now go back into some of the services we use. I've already touched on that for everybody. You need a plan for insurance, you need a plan for primary care, and you need to know something about your healthcare needs. How do you find people doctors? Well, we care for people from all over the state. So we ask, our questions related to where do you want to go for a doctor for primary care are, where do you want to go in the state? Do you want to travel? Do you want to be local? Do you have any preferences for type of doctor? Is your insurance going to have a network that creates some restriction for you? What do you like personally in a doctor? Someone who's chatty, someone who's all business, someone who gets into your private stuff or who doesn't? Those are different personality differences, aren't they, in terms of different clinicians? Are the doctors you're interested in open for new patients? Do they have visits at hours that you can go to? And so all of those are part of helping somebody find the right fit. Often we talk about if you're a person who has significant disabilities and will be dependent on your caregivers to go to the doctor, sometimes going to the same person as the person your caregiver uses is a good choice. Sometimes you don't want to go to the same people as your parents go to. So all of that's another kind of personal choice that we talk about. This is not a copy of the portable medical summary we use because ours doesn't fit cleanly on a single page. But I like this one just for a slide presentation because it pays attention to the multiple domains that are important to include. For our patients, once we put all that information on a page, it's usually 3 to 4 type pages. Some of our teams here at IU have done their own work on a specialty care. And so when giving the right information in a portable summary to the next person, for our sickle cell group uses this tool because it consolidates all the key facts that the next hematologist wants to know. And so having some pre-templated pieces of information like this, if your care is for a specific subset of types of patients, is very handy. When we train people to begin to assert more their own voice in healthcare, then we want to talk about, like, what do you need to do to be prepared to talk at the doctor's office, and how do you practice this? And I clipped this slide from New York Transitions Program because I just thought it fit nicely on a slide. But the handout on the right is the tool we actually use to train people in preparing for office visits. So it's their homework sheet. And before you come to a doctor's visit, you kind of collect your thoughts about, what do I need out of today's visit? Are there medicines I need refilled? Did something happen since I talked to this doctor last that I have questions about? What am I hoping to achieve? And then there's a second part of the form that is, what happened today and how do I summarize what I heard so I make sure that I processed it correctly? Would I love electronic health record discharge summaries to do that effectively for patients? Sure. Does ours? No. We print out things that are more about the business of medicine, unfortunately, from I work both in Cerner and Epic, and I find it hard for families to navigate the sometimes lengthy things that are on those pages, and I have to use a highlighter to say, this is the piece that's important. So we try to use tools that help with simplifying that. There are 4 or 5 now standardized transition assessment tools out there that have been validated. We use in CYACC the track by David Wood and CYACC. The website for it now is at Eastern Tennessee State University. And you can get permission to use that from them. I don't like any of them the best. This is the one we've been using the longest, and it's functional for us. We score a youth based on their self-report of their current state. Remember, I'm saying self-report because self-behavior and actions are not the same as self-report in lots of people, particularly teenagers. But self-report does in fact say, at least I have a clue what we're talking about here. And so it helps us identify things to work on next. And we make a total score that helps us say, you're well on your way, or you still have a bunch of work to do in terms of prepping for your future as a self-advocate. So let's talk a little bit more about people with chronic diseases or physical disabilities. We use this self-advocacy handout almost all the time because we talk about what are you good at doing, what is hard for you, and who helps you. And knowing, and are you any good at asking for help when you actually need it? These are all parts of the conversation of how to be a good self-advocate. And this form I'm showing you is one that we have written in particular for people with a learning difference, but you might have a similar one that says I'm a person with a physical disability, right? Or a physical difference. And so we encourage kind of practicing the script of how do I advocate for myself when I meet a new voc rehab counselor, when I go to a new doctor and I'm bringing somebody with me, but I still want to have a voice. So we practice these scripts or encourage that to happen at home for folks to find their own voice. There's a number of different apps for phones about transition. I think my current favorite one is the Healthy Transitions ones out of the Delaware, New York program, but I think these other two from McMaster's and Walter Reed are also handy and usable. There's a lot of different medication self-management apps. I guess MediSafe is currently my favorite because a lot of these have gotten bought up by different pharmacies, and so you have to use that pharmacy to access them now. And so MediSafe is agnostic of pharmacy, and so you can use it regardless of which your where you get your meds. We use stoplight action plans because they help organize the health education. They don't work as a standalone. I want to make sure I say that. They are a cue card, not the sole education tool. If you hand a person a piece of paper and you think that's education, then you're going to get what you deserve. But what I like about the study I'm showing you here is that with people who had relatively low literacy and health literacy, they converted what you would all commonly recognize as an asthma action plan into a pictorial action plan. And they were able to show that people did well using this tool. They were better at understanding how to care for themselves by using this tool. So because of that, we've created a host of our own tools. And if you care for people with physical and intellectual disability, often you're going to be conversant in chronic constipation. Probably 80% of our patients have chronic constipation. And so we work through what do you do to stay healthy? How do you know you're healthy in terms of your colon? What's a sign that your colon's having some kind of flare? And what are you supposed to do to adjust on your own? What's serious? Who should you call? What should you do while you're waiting for an answer? When should you get in an ambulance? And understanding this about your own needs, and many of our patients have many action plans because they might have a seizure action plan and a constipation action plan and a neurogenic bladder action plan and a VP shunt action plan. But understanding, and we've talked to the families on our advisory board, is having 5 plans prohibitive? And their answer is, if we need 5 plans because we're that complicated, we'd rather have them than not have them. And so we haven't found a way to make it simpler yet, the education, because it's not simple sometimes. Sometimes it's complicated. But we still find that families really struggle with understanding how the colon's supposed to work. And there's a lot of Miralax scripts that get passed around our community without fixing the problem, because people don't understand that constipation is more than how much medicine you take. It's about the liquids you take and about your activity level and about the fiber in your diet. And it's about whether you're really backed up right now and your colon can't squeeze, or you're really empty now. All of those things matter to your understanding of that. I do have a favorite video for this. We are using YouTube as much as possible for education. And if you haven't seen the Poo in You video from Colorado Children's, it is my favorite. It addresses health literacy with a nice paced, simple language, good explanations and definitions. They have a couple of other tools that I also use. Whoever does their video clips does a really nice job. Now I'm going to forget what the other 2 I use are, but I think one's for neurogenic bladder and one's for BP shunts. This is what a blank template looks like, because I just wanted to remember to say, no matter what your health condition is, you could fill in the items on this, couldn't you? How do I feel when I'm well? How do I keep myself well? What does a flare feel like? What am I supposed to do? What's serious? Who do I call? What do I do while I'm waiting for an answer? Other ways we encourage people to develop their voice is by finding other organizations that help with self-advocacy. In particular, our Special Olympics Athlete Leadership University has a health and wellness track that really encourages people to develop their skills in managing their own health. So I'm a big advocate of working with whatever you got in your state that helps you with things like this. Let's go over and talk a little bit more about intellectual disability and serious mental illness. If you have not seen the life course tools from the University of Missouri, Kansas City, I encourage you to look at those. We use these tools for families in a variety of ways. I just like this picture because it's a good thinking about where you want to get to in the future summary. It's too much, like pages with this much text are too dense, but it just what represents well on this slide. They have tools for the different phases of life course you see in the top right, as well as across all of these domains you see in the middle of the slide. And so they have lots of different tools that we use in small segments to address building skills. Making sure that families encourage their youth to be communicating and contributing to this conversation is really important. So we spend time with our health professional trainees teaching them how to interact with someone who's using an accommodative approach to their communication. We also work really hard that if kids have accommodative communication devices or tools they use at school, that they make sure they have them at home and for use in community as well. It's not okay to only be able to communicate at school. You should be able to communicate in all your environments. And we find a lot of kids using iPads with Proloquo to go at school, and then they're not bringing it home and they're not communicating at home. And, you know, obviously that's causes frustration. For our individuals who have very limited abilities to express their illness or pain, we use additional modified tools. I particularly like the Distat, which was created in the UK in a hospice for people who have limited voice and to understand what the person looks like when they're well compared to what they look like when they're ill. Families can recognize when a person with a severe disability is happy or ill, but sometimes I can't because I don't know the person. And so if the family pre-digests this and has this to share as part of their medical summary, it really helps future healthcare professionals. So we use this often for persons who are very limited in their communication. This is a tool we use to help persons with intellectual disabilities learn the rules of maintaining their health so that they can self-manage rather than need to sensorily perceive and problem solve. If perceptual reasoning and sensory integration are a problem for an individual, but they want to take care of their health, they might just learn that if I go to bed at this time and I get up at that time, I'm well rested and things go well for me. So this is now my rule because simple and concrete rules work well for me. I go to bed at 10, I get up at 6. Same for I drink this many glasses of liquid a day to stay hydrated, or I sit on the toilet this often a day to stay continent, or I remember to cut my toenails or change my underwear. All of those are things that some people need help with. And having them as explicit rules rather than inferential reasoning that isn't going well has worked very well for us in our population, particularly the largest population of folks with IDD who have mild limits. This works really well for. It also helps the caregiver take a little more of a step back. So nobody who's a young adult with mild ID wants their mom saying all day long, take a shower, take a shower, take a shower, take a shower, right? And if you know that my rule is I take a shower every 2 days and I follow those rules, then mom doesn't have to say anything. And everybody actually tends to be happier in that scenario. Here's another list of apps that we like. Do I have a favorite of these? I don't know that I have a current favorite of these, honestly, but we use these for measuring goals and having new chores or new activities you're working on. So the forming new habits in Stride might be my favorite for right now, but all of these have some value and different families like different ones, as you might imagine. I always pick apps that are free, by the way, because people don't have a lot of money who have disability commonly. And so there you might find ones you like better that are that cost a little bit. I just don't tend to use them in my practice too much. This is just a slide to go over the concept of comprehensive health checks. The reason I have that here is because this is from Baxter in the UK. By looking from a top to bottom approach, they find a variety of problems in patients before they've manifested as an illness. And this list is long, isn't it? And it's long on purpose. Like if you don't screen for hearing problems, a person might not tell you, I think I'm having a problem with my hearing. Thyroid disease is really common in Down syndrome. If you don't screen, you find it when they're already really symptomatic. So this is just an encouragement to think about how to do a top to bottom approach annually, 18 months, to help with heading things off at the pass. I could talk a whole hour about sexual health. Terry Cohenhoven has a number of books I really love. She does her work more geared for folks with IDD and also has this book I listed here specifically for Down syndrome. I love the work of the Vanderbilt Kennedy Center. These are all free. We use the Healthy Bodies book for everybody. They come in male and female gender. They come in English and Spanish. The new book on puberty, sexuality, and sex and sexuality, I think it's fairly newly out. I don't think that one's translated yet. It might be. I haven't looked, probably in a few months. These are some other books I use. The two on the right are also by Terry Cohen-Hoven. They do a very nice job of having low literacy, good graphics, approach to skills one needs in puberty. We tackle, like, how do you remove hair that's in places you don't want it, right? That's a question that people don't know how to deal with, particularly people who are in diapers. And when they grow up and their bodies are changing and they're getting hairier, how do you deal with hygiene in that circumstance? So we work through those kinds of problems. Sometimes we use PECs or other kinds of social stories. We talk about social skill development, certainly in our whole population of youth with autism. My new favorite Netflix show is Love on the Spectrum. Their second series is out there, an Australian relationship coach teaching persons on the spectrum how to approach relationship building when they desire to date, but are not yet being successful in that domain. I think when we teach about sexuality and touch, we also need to teach about some necessary things that happen. So the whole concept of when you come to the doctor, it is necessary for me to talk to you about private things, and we have to develop a way of feeling comfortable with that. It is necessary sometimes for us to touch you in clinical care, and we have to work our way through that. One of the, this is a very simplified graphic about touch that we use. There's another tool we use. Internet safety is its whole other area of safety. Another thing we do with smartphones is make sure that everybody has some kind of Find My Phone identification, geo-mapping app engaged, as well as an in case of emergency. And iPhone does a good job of having those embedded in, but if you have an Android phone, there are those apps that I've listed there, again, free, that you can use for both in case of emergency and a way for people to track each other to find them if they're lost. There are certainly other means for GPS location. Project Lifesavers is probably available in many of your states. We can also use GPS location tools through our waiver program, but knowing about those is important. When we talk about decision-making supports, we really do a lot. We try to do a lot of work with videos related to this as well, to help people understand the difference between power of attorney and guardianship and why you might choose one over another. Thanks to the Florida DD Council for a nice workbook they have on this content area. This is a tool, again, from Life Course to help think about where do I need help? How do I ask for it? And as a really important skill for everyone. I love California Developmental Disabilities website, Think, Plan, Do. These are 3 examples. They have probably 15 different tools. I'm highlighting a page each from the one on decision-making, how to manage your stress, and how to manage your money here, but they have many more than that. This is a better example of, there's usually in each of their handouts a think page, a plan page, and a do page to help you in working through decision-making skills. They also have a video paired with each of these tools that you can watch to see how a person with IDD uses these tools and encounters these situations in their lives. So I really like that whole website. I use it a ton. For the persons with serious mental illness, the big ad that we try to emphasize is creating a safety plan. The one on the left is a little higher literacy level. The one on the right is a little more simplified, might have pictures on it, but having an approach to talking about a safety plan for when your mental illness flares is really important. I've mentioned already that transfers of care should be warm handshakes. When we do our transfers of care, we've built relationships over 15 years with specialists and primary care docs around the state. We make sure that we provide a medical summary, the transition plan, any emergency care plans, and then we have a library of tools, pardon me, that we call chronic condition fact sheets. I'm going to show you an example next. We promise that we will get their backs when we're transferring people to somebody new and help them if they have questions. These are 2 examples of tools we might send. All of our tools try to be 1 page long because we think that in primary care we have about time to read 1 page and not more. And so instead of the 300-page Spina Bifida Association of America's guide, we use a 1-page guide that tries to help highlight areas where of things you might need to know if you're caring for an adult with this condition. Then we have a bunch of them also for devices like a vagal nerve stimulator that I'm demonstrating there. We use a lot of the autism treatment networks, toolboxes to help practices work on being more accommodative to people's needs. How do you take a blood pressure on somebody who struggles with that? How do you practice swallowing pills? We have a whole series of tools we use for this to help people. What do you do if you're afraid of blood draws? What are the steps to desensitization to help you do this necessary touch that's hard for you? We're lucky to have a center here in Indiana called the Hands in Autism Center. It's in our Department of Child Psychiatry. They will actually come out and help with training practices in how to provide accommodations for persons with IDD who need it. We use a big red dot to say, sit here next. We give them timers that let them know at what time are we going to be finished, and you got to be finished when the bell goes off, even if you wanted to do some more things, if you promise. And we use social stories to help with what's going to come next. I didn't show you the social story we use, but it's one that a resident did for us that just takes a picture of all the different places you're going to go to when you're at a CYACC visit and who you're going to meet. So you can see those ahead of time if you so desire. I couldn't talk about any of this work without showing you the list of different services and different organizations we work with. I don't think this one's complete, but it's a good starter set. These are articles that have come out of our work, and I'm going to stop sharing now to answer any questions.